Systemic lupus erythematosus. It's an autoimmune disorder where an atypical immune response results in a chronic inflammation and destruction of healthy tissue. In autoimmune disorders, small antigens may bond with healthy tissue, and the body then produces antibodies that attacks that healthy tissue. And that can be triggered by a toxin, medication, bacteria, or virus. The control of symptoms and the decrease in number of exacerbation is actually the goal to treating this disease, because there's no cure for an autoimmune disorder for this one. Other autoimmune disorders are things like rheumatoid arthritis, vasculitis, MS, scleroderma, that includes Raynaud's phenomenon, and psoriasis. The occurrence of autoimmune disorders increases as the individual gets older. Lupus SLE, or systemic lupus erythematosus SLE, it varies in its severity and progression, and it's generally characterized by periods of exacerbations, which are flare-ups. Exacerbations. You can get exasperated by them, though. Exacerbations are flare-ups and remissions. It's classified either as discoid or systemic, and there is a temporary form that can be medication-induced. Discoid SLE primarily affects the skin, and it's characterized by erythematosus butterfly rash over the nose and cheeks, and it's usually self-limiting. This is a picture when you go to Google Images. You always see that rash across the nose and cheeks. Systemic lupus affects connective tissues of multiple organ systems, and it can lead to major organ failure. I actually lost a sister-in-law to this. Medication-induced lupus can be caused by medications like procainamide, hydralazine, isoniazid. These symptoms resolve when the medication is discontinued, and it does not cause renal or neurological disease. It's difficult to diagnose because it's vagueness of early symptoms. Usually we see it in females that are between the ages of 15 and 40, and specifically the races African American, Asian, and Native American. Those descendants pose a greater risk. It drops in women following menopause, the incidence, but it remains steady in men, so that's an interesting little thing. If you get through menopause and not have lupus, you probably won't get it if you're a woman. Diagnosis of lupus can be delayed in older clients because many clinical manifestations mimic other ones, and they can be associated with the aging process itself, such as joint swelling, pain. It can significantly limit the ADLs in older patients with comorbidities. And they have an increased risk for fractures if corticosteroid is used for treatment with lupus. So what do we see? We see fatigue, malaise, alopecia, anorexia, weight loss, depression. We may see a fever, and that's also a major symptom of an exacerbation. Joint pain, swelling, tenderness, anemia, lymphadenopathy, Raynaud's phenomenon, which is an arterial vasospasm, typically in the hands or feet, in response to cold or stress. Findings consistent with organ involvement, so if it infects the kidney, heart, lungs, or vasculature, you're going to see signs and symptoms that are specific to those organs. And then once again, that butterfly rash on the face. Diagnosis happens through many tests, laboratory tests, autoantibodies. They are looking for an anti-nuclear antibody titer, which is an ANA, and that's an antibody produced against one's own DNA. A positive ANA titer in 90% of clients with lupus. Normal is negative ANA titer of the 1 to 120 dilution. So a positive ANA is what we see in 90% of the individuals. An anti-DNA is positive, and that's not necessarily specific to systemic lupus, but it's positive in a vast majority of the patients who have SLE. retractable nuclear antibodies, ENAs, specific for selected parts of the cell's nucleus. There's a whole bunch of them. I'm not going to test you on these, but there's the anti-Smith, the anti-Rho, the anti-LA, the anti-RNP, and anti-phospholipids. They would all be positive. So the ENAs are positive. A serocomplement of the C3-C4 is decreased. The complement system is made up of proteins. We know there's 9 major complement proteins. And these proteins work with the immune system, and they play a role in development of inflammation. C3 and C4 are diagnostic for lupus because they decrease due to the depletion secondary to an exaggerated inflammatory response. So they're going to go down because of the inflammation. We would see an elevated BUN and serum creatinine with renal involvement. Also, if we had renal involvement, the urinalysis would be positive for protein in our RBCs. And the CBC may show us pancytopenia. Okay, so for these individuals, we're going to watch for pain, mobility, fatigue. We're going to watch your signs and symptoms of their vital signs. Primarily, we're looking for blood pressure changes because they could have hypertension, edema. That could be from a renal compromise. We also would see a change in urine output. We'll listen to their breath sounds if they have a pleural effusion. If they have any pericarditis, we're going to look for tachycardia or inspiratory chest pain. We're going to watch for a rubor, pallor, or cyanosis of the hands and feet, and that would indicate to us they have vasculitis or a vasospasm, perhaps Raynaud's phenomenon. Arthralgias, myalgias, polyarthritis, looking at joint connective tissue involvement. Any changes in their mental status, which would indicate a neurologic involvement, like a psychosis or paresis or seizures. And then if they have renal involvement, look at that BUN and creatinine again. As well as we want to make sure we watch their nutritional status to make sure they're well nourished and small frequent meals if anorexia is a problem. If they have hypertension, we will limit their salt intake, of course. Medications, we use NSAIDs to reduce inflammation. NSAIDs are contraindicated if they have renal compromise, and we wanted to monitor for an NSAID-induced hepatitis. Corticosteroids we use for immunosuppression and to reduce inflammation. We're going to look for fluid retention, hypertension, and renal dysfunction as a complication of corticosteroids. And we want to make sure they understand not to stop taking them suddenly. Immunosuppressant agents such as methotrexate or Imuran. We use these to suppress the immune response. And we're going to look for toxic effects such as bone marrow suppression and increased liver enzymes. Antimalarial like Plaquenil. It's used for synovitis, fever, and fatigue. And we're going to have a look at their eye exams with that as well. They need eye examinations if they're on Plaquenil. We want to educate these individuals for sure, and to make sure they understand they use therapy, OT, PT, support groups. We also teach them to avoid UV rays, sun exposure. They should use sunscreen when they're outside and exposed to the sunlight, and a mild protein shampoo to avoid harsh hair treatments, especially if they're having trouble with alopecia. They can use steroid creams on their skin rashes. They want to report any peripheral or periorbital edema, signs and symptoms of infection related to immunosuppression, and to, once again, avoid crowds, people who are sick. We don't want any exacerbations. Complications include lupus nephritis, which is renal failure. If they're unable to be managed with immunosuppressants and corticosteroids, they can experience renal failure secondary to glomerular nephritis. That happens to be a major cause of death for patients with SLE. and a renal transplant might be necessary. And then pericarditis and myocarditis, inflammation of the heart, vessels, the pericardium. It's also secondary to SLE, so we want to look for signs and symptoms of those complications.